Well, good morning, everybody. I'm Mike Cavan. I'm a psychologist and professor in family medicine here at Creighton University. I want to welcome everybody to, I think, what's going to be a very, very interesting panel discussion today on promoting awareness of mental health in the global community. I'm not going to spend a lot of time talking. I want our speakers to do that and provide you with lots of opportunities to ask questions and get comments and such. So I'm going to push this over to our speakers, let them introduce themselves, talk a little bit about their connection to mental health and global health as well, and then we'll open it up for, I hope, a very rich discussion.
Great. My name is Nick Gunzel. I'm a psychiatric nurse practitioner, and I'm an assistant professor of mental health nursing at the UNMC College of Nursing. So I work 1 day a week as a nurse practitioner, do some teaching and research also. I first became interested in mental health when I was in an undergraduate nursing school, and I saw that technology was a great advancement for many areas of healthcare, but in large part we tend to lose the patient within that. You can go into a room and you can have 14 different monitors on the patient, and you assess all those and then see how the patient is doing. And even in some extreme cases in the ICU, we might sedate a patient because they're getting in the way of their care. But I contrast this with mental health, where we really have no ability to take care of a patient effectively without putting that patient at the forefront of our interactions. So I've had some involvement in global health, worked on some mental health issues in Mauritania and Northwest Africa. I've also worked with some refugee populations and some Native American populations.
I'm Nora Bazum, and I'm a clinical social worker. I work primarily on the Pine Ridge Indian Reservation in South Dakota, and my specialty or area of focus is working with people who are affected by fetal alcohol spectrum disorder and providing services to them and their families and caregivers. What first interested me in this field actually was becoming a foster and adoptive parent. I used to actually be a pediatric nurse, and after I adopted my first 3 children out of foster care and realized there was no services for people with fetal alcohol spectrum disorder, I kind of went back and reinvented my path in life to try to serve that population. So that's what really got me interested in my field and has brought me to where I am now. And as far as the global community, I basically work within Rapid City and then the Oglala Lakota Nation. So thank you.
Good morning, everyone. I began training in psychiatry as a resident at Hopkins when I first thought about residency. I actually wanted to do internal medicine. I already had a child by the time I finished med school, so the choice was, and it sounds very simple, but it's a lot more complicated than that, was every 4th day call in psychiatry as opposed to every other day call in internal medicine. And I interviewed for both, and I thought, I'm not going to see my child for more than 3 hours every 3 days if I did medicine. And Osler medicine, believe me, was just horrific. And when you saw the people who worked there, they didn't look happy. The people who worked in psychiatry actually looked happy. And that was a starting point. In terms of my exposure to global mental health, I come from India. When I first started my residency, one of the questions the chair of the department asked me was, if people like you leave your country, Dr. Jairam, what happens to people in your country? And that was a very profound question for me that I thought about for a long time. And when I first got the chance, after my children were grown, to join Rotary, I was already a Rotaractor at age 19, so doing humanitarian service was something I'd been doing for a long time. Rotary did not permit women to join. When they did allow women to join, and I started, there was no looking back. My first thought was to give back to the country of my origin, and that's how I began my mental health program in India. You'll hear about that later. In terms of ethnic groups that we treat, at Hopkins, 83% of the patients who come to my service, it's an inner city service, are African American. We have a large Hispanic population that's very close to the hospital that we treat. We treat people who come as scholars to the School of Public Health from all over the world, who really become psychotic once they're there, or are terribly depressed, or are suicidal, and those patients get admitted to my service. So I've seen young people from all over the world that we've treated and treated successfully. So that's my exposure to a number of ethnic groups and cultures and differences in treatment. Right now, we have put together a research program to evaluate young people in an Indian reservation in Maryland, where the suicide rates among children aged 15 up to young adult up to 24 is extraordinarily high. And rates of suicide in that population are steadily rising. So we are going to do a study to see if there's any preventative way to engage these patients or potential patients even before they get to that point by doing virtual groups using a computer language processing algorithm, which would be accessible for anybody young who would prefer to do that than travel to some urban setting. And the cost of it, the time that's spent in it, all of that can be completely bypassed if we do and are successful with a program that engages them and removes stigma at the same time. So that's just a small portion of what I've done.
I just wish to ask in general, I'm still training right now, I'm thinking of like when I grow up, okay, this is what I want to do. What are some things that you can start doing while you're training in residence? What are some things that you can start preparing your mindset to prepare the groundwork for the work I want to do when I'm done with my training? Or something that I can start doing now that incorporates that journey. Just, not just the way when I'm done.
And you're a first year resident. Is that a question for me? You can do two things. One is find out if there is a clinic for a particular kind of population in your, whether it's in your department or Department of Medicine or Public Health, and volunteer to go there, see what happens. You just have to experience it and begin to see how they're dealing with things, how is it different, what are things you observe that come up in that context. That's one. And second, you've gone through all these scores of volunteer efforts that are being presented. If you're able to get a grant to go on a trip abroad, to actually do a 10-day trip or an 8-day trip, whatever is possible, I'd suggest you do it. So there are grant funding agencies that specifically look for medical students or residents to do a rotation. So at the Center for Global Health at Hopkins, for example, there are field placements that are many, many field placements where young people can go and do a rotation anywhere of a minimum of 3 weeks to more. And they provide a stipend that's about $4,000 for you to go. There are other such granting agencies, and you could look at them. I was looking at one just yesterday called Trialect.com, Trialect, and they look at, there are many, many agencies that fund rotations to do global health work or any kind of work, even in another state. Take a look at that.
Yeah, I think the language barriers tend to be the biggest difficulty probably in mental health versus any other area of medicine where things are sometimes a little bit more straightforward. There's so much nuance and cultural implications that vary. So when we're treating patients who don't speak English, or even those who speak English and come from a different culture, that adds a lot of complexity there. So I think having a good interpreter is great. Unfortunately, I think it's a double-edged sword with the technology. In some ways, it's increased our ability to provide services to languages that are not commonly spoken in that community. But on the other hand, having someone who lives in Texas and is translating over the phone, we lose a lot there. So thankfully within our some of our clinics, we're able to have local translators who come from that culture, who are able to come in with that person and provide some interpretation and also some additional context and say, well, in our experience, this type of thing is common, but this is not that type of thing. But yeah, it's a major difficult issue, and I'm not sure anybody has a perfect answer for it, but we can try our best.
Question is a great question because primarily that is the biggest hurdle if someone wants to go and volunteer to work somewhere. So unless you have a local translator who's there and can help you, it's impossible for you to communicate with patients. Also, psychiatric symptoms and phenomenology is not easy to understand, even when both parties speak English, because there are regional differences and there are cultural differences, but also maybe slang of a particular kind of language you may not understand, even if you know the written language well. So it's very important. At Hopkins, we have people who translate 200 languages, but even there, you can lose something in the translation because the person chooses not to just translate, but to interpret. And we have to repeatedly tell the translator, we don't want your interpretation and judgment, we just want your literal translation. So that can be hard, and we've known which translators are good for which language. So we say, I want Maria for this, or I want Dr. So-and-so for that, because there are subtle nuances that may very well decide if the patient has psychosis or not. And you have to be doing this in the best interests of the patient to not stigmatize them with something that they really don't have.
I work as a psych nurse, and majority of our patients, either come in for detox or suicidal, and they still, I still see a stigma even here in the States with depression. It's not a conversation we can easily have with an employer or things like that. And I know it's certainly, in Africa, I know in Kenya we have one main national mental health hospital, and I've seen findings where there's one psychiatrist for almost 100,000 people. But I'm just wondering, from your travels experiences, what the major conditions are, and then how do you navigate that stigma where, conversations, how do you start that, and then how can we address that? Because I know some people walk up, with their relatives or people in the communities because they don't have resources, so they keep them chained or things like that. So I'm just wondering, how do you, go into these countries, and then you also want to be culturally sensitive, but then also create this dialogue of using that stigma and kind of minimizing patients. So just curious what you say.
You mentioned even just going to other countries, but I'm going to just take that from even just going within a different culture in the United States. Where I work in the Oglala Lakota Nation, there is a lot of barriers to even discussing mental health because most families, especially if you're talking within a traditional family, they look at it as a spiritual weakness of someone if they're not able to deal with their issues. And we have a lot of families, like when we were doing some suicide prevention work within the schools, we'd have parents literally come in and remove their child because they didn't want them talking to a mental health provider. There's a lot of stigma around that, and trying to help people understand that, you are there to help and that what you're doing isn't going to harm them. But I know with the work that we've done, one of the biggest things that we really had to realize, and I grew up on Pine Ridge, so this is something that I was aware of, but a lot of the people that I work with really had to struggle to understand, is we had to change what we were doing to match the cultural differences. So we incorporate a lot of the spiritual part of their culture in the work that we're doing, the different ceremonies that they do. When there's been a suicide, we bring in like a medicine man and have a wiping of tears ceremony. Sweat or an EP is a huge part of that. And so, you know, having to kind of change your viewpoints and realize that if you can listen and meet people where they're at, then they're going to be more likely to listen and meet you partway too. So that's definitely important. But the stigma is still huge. And, you know, she was talking about suicide rates in Maryland, and, you know, the suicide rate on Pine Ridge for teens is 4 times the national average. And while I worked on in the Pine Ridge school system, we had a 5-year-old complete suicide. And so, you know, really looking at what's going on and trying to help people become aware that it's okay to seek some mental health services. But that's really, really hard to get people to feel comfortable and feel like they can do that. So.
Yeah, I mean, that's a great point. I think, obviously, stigma is a major issue across all countries. Hopefully, we're making more progress here. It's definitely something I saw during my time in Mauritania, where also, probably similar to other countries in Africa and other developing places, where if somebody's psychotic, for example, they may chain them to the wall and leave them there for weeks or months, unfortunately, if they don't get the help that they need. But thankfully, there are individuals like the nurse practitioners I work with there who would find out about this, go into the home, give them medication, get them better so they can get out of those chains. So I think that kind of starts a little bit of the conversation there, that once they see that these medications and other forms of treatment can be helpful, that they cease to think it's because of possession of demon or other types of explanations that they had been using before. So they've also had projects there, for example, where they have a play that they put on for communities, where they'll have an imam go with the patient and their family to see a psychiatrist or other medical professionals, so that they can gain the awareness that this medical treatment is not contrary or not against their traditional beliefs, but that they can kind of coexist in harmony.
You will see stigma mentioned in just about every presentation at this conference, because it's stigma because someone is deformed, it's stigma because someone looks peculiar, it's stigma because of some genetic inheritance or trait that makes them look different than you or I, and it's stigma because the person is labeled with something that nobody understands, and therefore they want to avoid that person. Even in the hospital, for example, psychiatric patients are seen at the lowest rung of the ladder. They are not seen as people that anybody wants to wait on. So surgeons, in particular, have a disparaging way of looking at our patients. So the minute somebody misbehaves, it could be because the person has a brain tumor. They haven't even taken the time to look at it. But they will immediately get triaged to the psych back area where nobody wants to see them. So we fight the stigma every day, even among our colleagues. In particular, our most difficult colleagues to engage are orthopedic surgeons and oncologists. And frankly, oncologists see people who are dying every day. They should be the most reasonable and the most open for comforting words for their patients. The nurses do it, but the physicians, I don't know if it's part of the denial they need to have in order to be strong to treat those patients, but they are the least informed about their patients and the least averse to learning more about them. So stigma is something you're going to see every day in various forms, and you'll have to fight it. One of the ways in which to fight it is to address it directly. You cannot simply work around it and act like it's not there, but you have to educate the people who feel the stigma and practice the discrimination. And you may have to address it in a little bit at a time, one piece at a time. And when they see that you're managing the patient very well, like he said, and the person's transformed after treatment, they become a believer that psychiatric care really is essential. Or, God forbid, if their father is talking suicide because now he's been diagnosed with cancer, or his wife is now in postpartum depression, then they begin to see that psychiatry pretty much encompasses the person's whole life. And the most gratifying thing for us, and I'm sure you both agree, is we transform the individual. When that person leaves the hospital, it's a different person. And that kind of gratification you don't get from just removing an offending tumor. Believe me, you don't. And the family sees it, the children see it, and they become productive citizens. That's an incredible feeling you have of doing something for a patient. And if your colleagues can see that, they do understand that they have been behaving in a way that's not beneficial to the patient.
I just have one other comment on stigma is that, thankfully within the U.S., I think we're making some progress in addressing stigma in mental health. This has been the case, you have celebrities, actors, people coming out saying, I've had depression, or I've had bipolar disorder. Unfortunately, it hasn't extended to conditions like schizophrenia. And one kind of area where we haven't advanced as much, I think, is with addiction. So we obviously know that addiction is a major problem for people in all walks of life, and numerous, celebrities have had addiction and died from addiction. But I was curious or disappointed actually last night in the film when, hopefully many of you saw that, where the filmmaker asked the man, why do you drink? He said, it's my choice, it's what I want to do, basically. And I thought that was unfortunate that it seems he's internalized the stigma as far as what society has told him about addiction. Because really when a person is in a state of addiction, they don't have a rational choice. I mean, I can put a gun to Nora's head and tell her to drive to California, and she might drive to California, but we'd all recognize that's not her choice. So when you're going through the misery of withdrawal, drinking or injecting, smoking, whatever, is not a real rational choice. So when people end up what we view from the outside as choosing to drink rather than taking care of their kids, that's not really a free choice that they've made. And unfortunately, there's a lot of effort that we still need to make in addressing that type of stigma.
I can add really fast because I loved that you brought that up. The thing that is very hard when we're working on Pine Ridge is the addiction issue, and how many people just view it as they just need to stop. And when I worked in White Clay for years, every time you'd see someone there who was intoxicated, the first thing they always did was apologize to you for being there and for drinking. And I found that to be heartbreaking, that they felt that they owed an apology and an explanation for why they were there. But, that's kind of that stigma of addiction, and it's your choice or you're doing this. And when trying to get funding for fetal alcohol spectrum disorder services in Washington, what I always get is, well, women need to just stop drinking because then we wouldn't have FASD. Well, that's so wonderful to just say that, but that also places it at their feet as their fault. And so when I hear the term, it's 100% preventable, it kind of actually pisses me off, because that's totally taking out of the entire picture that there is addiction and that addiction is a disease. So thank you for bringing that up.
What does treatment look like for mental health globally? Do you still see like medication dependency like there is in the United States? Is there behavior modification, lifestyle changes, especially for if you're working with someone with schizophrenia, let's say in Ghana, how do you implement treatment for that?
Well, I think, there are a variety of things it could look like. And, really in Mauritania, we initially went there hoping to find all kinds of local solutions and things that they had developed. But when I visited one family whose son had been chained up because he had schizophrenia and became violent, his father told me directly, if he goes 1 week without this medication, we'll have to put him back in chains again. So I think in cases of more like mild to moderate mental health issues, hopefully there are a therapy or other kinds of traditional practices that can be helpful there. For example, Native American traditions, they could do sweat lodges, smudging, things like this. But in the cases of more severe disorders, when it comes down to what we suspect is a more neurochemical imbalance, that the medications are really the key there as far as we have developed.
And I think there are programs that are set up to try to help, but I would agree that, medication has to be in the picture at some points. There are cultures that won't look at medication or are very medication resistant. But like with schizophrenia, the first episode psychosis program, where you're trying to get them on the absolute least amount of medication possible so that they can still function, that program is hugely successful in communities that are using it. I don't know that it's used globally. I know it's kind of new even to the United States. But, you know, there are lifestyle changes and things that can be done for a lot of different mental health disorders. You want to comment, or do you, you want to start, or do you want to start?
So, prevention is a very broad term. One of the questions people always ask is, I didn't know this could happen. I wish I had known. So, in the United States, we have a lot of public service announcements. We have people coming on television talking about their illnesses and how much better they are. Those, I think, really help people understand that, number one, there's nothing to be worried about if you have a mental disorder, and two, that most of them are treatable and can be controlled to a point where you function very well. I think those are very important, and we must continue to give hope to people, because today you and I may be well, tomorrow I might have a stroke, and I might have a stroke-related depression. So there's no way to know when or how someone is going to be affected. There's a great deal of research in mental health now, and we know a whole lot more than we did even 20 years ago. So we know, for example, how HIV is caused. We know, for example, HIV is completely treatable. In the 80s, when we first discovered treatment for HIV, believe it or not, most people thought they shouldn't even touch a person who's HIV positive. And there was a huge amount of stigma and pushback, even in the communities where it was rampant. So it's very, very important to understand that a basis of science is something that you can offer people and you can talk about, because that's what gives them hope. There was no treatment for infectious disease decades ago. Now we have medications that will completely eradicate the disease. Rotarians are this close to eradicating polio in the world. Think about India, 1.3 billion people. 170 million children get immunized in a single day by Rotary volunteers. And if that country as large as that could actually eliminate polio, there's hope in this world for mental illness, believe me. So people really need to actually talk about how hopeful it is to get treatment, how you actually emerge as a real person. I talk to my patients all the time about how many presidents of this country have been treated. That's the way to decrease stigma. That's the way to offer hope. I also say, look, I've been in this profession for close to 30 years. Do you really think I'd be making a living and living well if I wasn't curing people and they weren't getting better? I would have no practice. I've got, people break down the doors to come in for my practice. Why do you think that is? It's because we get people well. And we get people well at a rate higher than medical doctors who continue to treat patients with rheumatoid arthritis, with COPD, with stroke-related problems, where they never get cured. So you need to make the point that mental illness is far more treatable and possibly curable than many other chronic medical conditions. But people don't know that, so we have to educate them. So one is raising awareness, two is educating them, and three, actually demonstrating good outcomes, those three.
Yeah, the lack of prevention has been one of my main frustrations with the mental health field, and that we don't have a corollary, anything correlating to other forms, other prevention in other fields. Mainly when we talk about prevention, what we're talking about is secondary prevention, where we're detecting it early, but I would say this is not really true prevention in the form of that's going to benefit people the most. Now, I would say there are 2 points that we can look at. The first, I would say, is prevention efforts for mental health need to start from conception or possibly even before conception. There have been a number of risk factors identified that take place during pregnancy, which can increase the risk that the child will go on to develop schizophrenia. So these are difficult studies to do because we have to examine the risk factors and then 25 years later find out the outcomes. And with rare disorders, this just doesn't tend to be very feasible unless we have large national registries like we find in Northern Europe. The other factor I'd say in prevention is more I'd kind of say social. So when we have a family there's a history of schizophrenia, we can counsel them to help really talk about things like drug abuse, which can trigger an underlying genetic predisposition to developing those disorders. We can also look at increasing social support. So I think with many of our high pressure, modern civilizations where everybody's supposed to be their own island, is supposed to be independent and not supposed to need any support, this really puts people in a position where they can become susceptible to developing things like anxiety or depression when they don't meet societal standards.
And I'll be honest, I kind of cringed when prevention came up, just because in the population I'm working in right now, first of all, we have a lack of providers for any sort of mental health work at all. And then you talk about how do you start prevention when you have a 60 to 80% addiction rate, and when the sexual abuse rate right now among youth is 100%. In the last study we did in Pine Ridge High School, every single child had been sexually molested by the age of completing that study. The IHS number is 9 out of 10 before the age of 18. I took students there and had a student come in and said, I don't understand, everyone keeps talking about putting all their clothes on before they go to bed. And I said, go back and ask the question why, because I'm not going to answer that for you. I think you need to ask someone. And she came back in crying, because the reason that kids in our population that we're working in are putting all their clothes on before they go to bed is in the hope that the person who is trying to molest them will pass out before they can get everything off. When you're dealing with the trauma that's happening in the population I'm working in, prevention is just kind of so far on the back burner right now. We're just trying to meet the need, and there just needs to be so many more resources available before we can even look at prevention at this time. So that would be my answer to that.
So when I said prevention's a very broad term, there are aspects of prevention we practice in our everyday treatment. So for example, how do we prevent relapses in patients with schizophrenia? There are medical ways to do this. There are instructional ways to do this. There are family support ways to do that. And there are ways in which families in certain countries carry on the burden of their loved ones who have schizophrenia way better than in the United States. And one of the reasons is that the family doesn't allow the young person to leave the home if they're incapable of managing or fending for themselves. So patients with schizophrenia in India, for example, fare much better than Western countries, 23% less relapse, because the family assumes the burden, they're protected, and they live within the household. So there are aspects of prevention that we can learn from certain cultures where things have occurred better than in the United States, where someone's kicked out of the house just because they're 18 years old, whether they're capable of doing what they need to do at that age or not.
So my comment is twofold. One, I wanted to comment on the alcohol on the tip yesterday. So one of the things that tended to happen, which is something that is seen with patients, is that initially he only as me, myself, and I kind of thing, but later on in the tape, it became obvious when he had rejoined his family and had abstained for some time, and now recognizing how some of the previous trauma in his childhood was contributing to his present state of mental health, which is something that, as you rightly mentioned, is something when we meet patients, bringing those together and sort of combining some of these island of things that they think are random occurrences that are leading to their current crisis. That educational aspect I found to be very important and helpful. My question would be in the scheme of when it comes to even recognizing aspects of mental illness, say for the people that have been to Africa and in the Indian context, what are your views in terms of even recognizing, say, depression, and this is labeling it as what is called, and then, so what is the state of that at our current point in time? Two, what are the things that are being done, or if you know things that are being done from those societal points or from building and engineering the way that the society can recognize and handle it? I don't know if you guys have any points or thoughts on that.
Yeah, that's a good question, and it's kind of interesting when you bring that up. And when I look at it, most of my patients here would never be treated in Mauritania for, I think, a number of reasons, in that they don't recognize mild, moderate depression, anxiety as really mental health problems. You have to have a very, overt form of mental illness to really, for people around you to recognize the need for treatment. I'm not really well aware of, campaigns or things that are going on to teach people about symptoms of other disorders. I think they're mostly focusing on the more severe disorders and then hopefully move forward from there. But another problem comes up, that lack of providers and lack of access to care. In Mauritania, I think there's about 3 million people, and they have, I think, 3 nurse practitioners and a couple psychiatrists last I checked, and they're all located within the capital city. So to treat someone who lives 12-hour car ride away, which they don't have a car, it's really not feasible. So I think it has to go hand in hand, where they have to increase capacity for treatment and then increase at the same time public awareness to bring in people who can benefit from that help.
I will be talking about some of what you've asked this afternoon, so I don't want to say it now.
You mentioned a few times situations of lack of providers. When those providers are overloaded or overworked, how do you manage the mental health of the providers?
That's a great question. I think burnout is huge in areas where there's a provider shortage, because there are people attempting to do the work of 12 people themselves. And I think, vicarious trauma and all of those things are a lot more common when you see that. I know, I've worked almost 17 years with the Oglala Lakota Nation, and seen a lot of great, wonderful groups come in and attempt to do work in that area. And they make several mistakes. One of them is, I don't think they're prepared for the level of trauma that they're going to deal with. I'm going to say it's like wartime trauma. I mean, the stuff going on is incredible. And I have seen people literally have like a mental health breakdown because they're just not ready for that. And then the second thing is not attempting to learn about the culture they're coming into before they come. And so they come with a great prepackaged program that doesn't in any way meet the needs of the population they're coming into. But yes, as far as taking care of themselves, this is why most people and most programs have not lasted on the Oglala Lakota Nation, because people come in and they burn out really fast. They burn bright for a year and then they're gone. And that just means that the provider shortage is even bigger. So.
Self-care and compassion fatigue, things like this are topics I think are growing in the discussion. So we've had conferences and retreats and things that are focused on these types of aspects. Unfortunately, I think a lot of people are too busy, unfortunately, to attend the workshops that they need. But I mean, there are efforts being made, and hopefully we'll make more progress on them.
This year's American Psychiatric Association president's theme is physician burnout and how to avoid it. And one of the reasons is that somehow, I think miraculously, everybody expected, including some of us, that if Obamacare came into the country, immediately everybody would obtain care where they were supposed to be getting care, in their primary care clinics or their doctors in their neighborhood, and we would no longer have crises all over the place. Well, it's just the opposite. Our emergency rooms are overcrowded. People are backed up, at least 25 deep in the psych emergency room. We do not have enough staff to handle this. People cannot just go home. There's no such thing as 8-hour shift. You really have to wait until the problem is taken care of. There are many rules and regulations to follow about where and when you can send the patient. It's an extraordinary amount of stress to deal with constant patients who are suicidal, but also homicidal and violent. The number of violent patients has increased since I first started residency. There are times when we have as many as 9 security on our unit in order to be able to deal with patients. The kind of drugs that are being sent into the United States from China it's incredible. If there's a sure way to destroy the American psyche, one way is to do cyber warfare where you don't know what the heck you're doing with your computer. And the other thing is to actually send cheap drugs into the community where the most vulnerable populations exist, and they buy it for like $5, and they're totally psychotic. We cannot track them through lab tests, and we have no clear idea of how to treat them except to treat the psychosis. That kind of stuff has increased enormously in the last decade. So physician burnout is a big issue we're talking about. And we constantly watch who's going into psychiatry and who isn't, and who, what is the residency production line bringing in, how many medical students are choosing to go into psychiatry and not. And I always sell the big points about why they should do psychiatry, and I can tell you some of them if you want to know at some point. But there is this real crisis of, even when there are so many bodies in a wealthy country with a lot of people actually there to staff your units and your emergency room, the stress is incredible. So we really have to think through resource consumption. And although in poor countries there are way less resources, believe me, there are 4,000 areas in the United States that do not have adequate resources to treat the mentally ill. So that's something I think lawmakers, people who are battling about silly things in Congress, really ought to be thinking about this. The ones we've got are. So I think the science is very attractive to young people now. So there are discoveries with genetics. There are discoveries with, actual imaging techniques. There are discoveries with imaging tracer techniques that tell you which area of the brain is affected. We're very close to actually having a diagnostic test that could be available in a lab somewhere to say, will this person respond to this particular medication or not? So you're not down some kind of a, crazy, tortuous path of figuring out what works for this patient. And secondly, we may very well be able to say, in this particular patient, this SKA2 gene predisposes this person to suicide as compared to the same kind of stressors in another person who does not have that genetic inheritance. I think we're close to that. That is very sexy for young people. They want to join because it's not like some kind of voodoo stuff they do in psychiatry, but it is actually medicine to the core, where we have diagnostic tests, we have biological processes identified that say what's causing the disorder. I know some people here are very interested in autism, and that came up. Autism was first coined and described at Hopkins, and there is a huge amount of research in that direction to figure out how to prevent it once it occurs and you recognize it. What do we do to actually help the parents of these autistic children? That is mainstream medicine, and that, I think, is what young people want to hear, because they want to see promise in the future. Nobody wants to hear, oh my God, we're all so terrible, and then you leave it hanging. Nobody wants to hear that. I mean, all medicine was driven by people like yourselves, young people who create, think, and move the country forward. So you really should be doing the research, engaging, and figuring out how to help those people who need it the most.
a little bit, and not just kind of, put you on a waiting list to see a psychiatrist or a psychologist. So I'm wondering if that's something you think should be done where medical trainees can.
There is required medical training. It's a very rigorous process of training for us, for those students that we teach. For years and years, for decades, I've had a medical student every month on my service, sometimes two. And they are required to go through certain process of evaluation, of talking to the patient, talking to the families, gathering information, formulating the case, figuring out what kind of treatment is needed. They are trained to do that. But in less well-endowed countries in terms of resources, it's given a very cursory, glance. So even in a major metropolis like Delhi or Bangalore or Chennai, the medical students' training in psychiatry is not as emphasized as it is in other fields of medicine.